All right, looks like we're coming back. We ready, Laurel?
We are ready. We have Kenneth is going to introduce our next speaker. So welcome back, everyone. And Kenneth, if you, with your wonderful introductions, our steering committee chair is going to do our next introduction for our next speaker.
Thank you, John and Laurel. It is an honor to see you and introduce you, Dr. Martin. Dr. Martin has distinguishing administrative, professional, technical, and clinical experiences in hospitals and public health services and systems. This includes carrying out interdisciplinary teaching, research, service, and public health practice, and epidemiology within local, national, and international settings. Educated at the New School for Social Research, Dr. Jamal Martin completed his undergraduate degree at Hawaii Pacific College and graduate degree at the University of Hawaii, Manoa. He received his postgraduate training in epidemiology through the University of Michigan and the Centers for Disease Control and Prevention in Atlanta. Following completion of his doctorate at the University of New Mexico, he briefly studied at the O'Neill Institute for National and Global Health Law, Georgetown University. As a past director of UNM's Peace Studies program, Dr. Martin recognizes structural violence as a global health equity challenge and advocates for strategic peace-building education and health diplomacy. His current research focus lies in forensic epidemiology, public health law, mind, brain, and education sciences. Equally important, he also instructs on diverse subjects including ethics, philosophy, public policy, and religion. As a former clinical assistant professor, family and community medicine, he presently lectures in Africana Studies and serves as the Associate Vice Chancellor for African American Health at the UNM Health Sciences Center Office for Community Health. And so, wow, with some excellent credentials, I am so excited to welcome and honor you, Dr. Martin. Welcome. Thank you.
Thank you, Mr. Winfrey. It's a pleasure to see you again.
You too.
Good afternoon, everyone. Let me go ahead and start to share my screen so that we can take a deep dive into the subject material. What I want to say is that as we talk about chronic diseases, I want to say that this talk is probably going to be unlike any other talk that you've ever had before in terms of chronic disease prevention. And what I really want to do right now, you saw the title where I said this is a root cause analysis and root cause analysis squared, meaning that it's not just a root cause analysis, but it's also about action of syndemic diseases and health inequities in the United States. And before this presentation began, I gave you folks, sort of 3 learning objectives that I was thinking about. And this is a work in progress because this, I think, is another chapter in the book I'm working on. But for the option number 1, this is about reimagining what public health services would look like and how we look at chronic diseases under a racial lens that says let's remove supremacist ideology and institutionalized racism. So we're going to talk about power analysis, and we're also going to talk about the advocacy for building a culture of health. So without further ado, let me just sort of jump into this. The first part of this presentation, which is in 3 parts, is really about critical thinking and learning. And I'd like for you folks that when I talk with the students, I always start off with a lecture for the first week or so on critical thinking, because we're always telling students to become critical thinkers, but we never really tell them how to do it. And unfortunately, I don't have time to really sort of go through that now, but I am going to give you some highlights. And that is, think of critical thinking and learning as an intellectual trait that gets back to, some very metaphysical issues in terms of virtues. And so when we're talking about critical thinking and learning, we're really talking about being fair-minded, developing intellectual humility, intellectual courage, intellectual empathy for social justice in particular, because if you don't develop intellectual empathy for social justice, you wind up really sort of operating a fear network and becoming a sociopath because you don't care about the suffering of other people. So by and large, since we're living in a, SARS 2.0, COVID-19 climate, pre and post, people are beginning to understand racism as a public health crisis. So I want to kind of focus on some of those issues for a moment. But the basic activities in critical thinking are investigation, interpretation, and judgment. And with those three activities, investigation, interpretation, and judgment, we really have to find evidence or data that will answer key questions about the issue at hand. And the requirements for that data, that information, is that the evidence must be both relevant and sufficient. The interpretation, we have to decide what that evidence means. And again, the interpretation must be more reasonable than competing interpretations. And then finally, judgment. We reach a conclusion about the issue. And the conclusion must meet the test of logic. And all this fits in with a lot of neurological studies in terms of the essential functions of the mind: thinking, feeling, and wanting. And our thinking helps us decide when our thinking and feelings are in alignment. Then it's easy to understand what our motivation and our desires are. Unfortunately, people are always caught up in a trap where we react rather than being proactive. And so we jump from our emotions right to decision-making and motivation. Eurocentrism. This is from a cartoon, from a comic strip that was very popular and even turned into an animated series some years ago about this young African-American male by the name of Huey, who was very, very woke in many ways. And he was talking to his young cousin, and she said, "Huey, what does Euro whatever you said mean?" He said, "Eurocentrism?" He said, "It's when you eliminate the African perspective and marginalize or omit people of color, their contributions, their experiences, etc. Understand?" "Not really." "Did you ever watch Friends?" "Yes." He said, "Then you understand." And that's, I think, one of the things we have to think about when we talk about undoing racism and in public health and institutional health, that, we're always looking at this through the lens of Eurocentrism. And there's an old African proverb that says that until the lion begins to tell his story, then the story of the hunt will always glorify the hunter. So people, if you look at critical race theory, it's important to hear people's narratives and their stories, because people carry their histories in their bodies. We know that from social epidemiology and other issues that people, their history is embodied. They carry it. So as we talk about institutionalized racism, we have to talk about the initial historical insult, the structural barriers, the inaction in face of need, the societal norms, the biological determinism, and unearned privilege. And how, when you look at this model to the right, it's really about, this is less about individual racism or cultural racism in some ways, but institutional racism. And while there's overlap in terms of this, in terms of the racial hierarchies of white superiority and racial beliefs and actions which are justified by people, this is more about the production and maintenance of that racial hierarchy. And that's why I feel that we need to talk more and more, as people are saying now, about institutionalized racism or societal racism or structural racism. Brief note, I grew up doing political apartheid during the last days, a decade of Jim Crow. And so I have very acute memories of being told that I can't sit at this counter because I'm colored, which it still says on my birth certificate that I'm a person of mixed race. And so while individual racism may be getting better, it's the institutionalized issues that we haven't really talked about. And so we're going to look at some of them for a moment. So when you look at this pyramid, you'll see that when people usually talk about white supremacy, and when I talk about white supremacy, I'm not talking about skin color, folks. I'm talking about an ideology. I'm talking about a mindset. Again, I am not talking about skin color, but a mindset. And that mindset, which is embedded in our educational system and other things for, a good 200-300 years or more, is basically says that someone says that I'm superior, and therefore someone else must be inferior. And if I deem them to be inferior, then I can treat them in an inhumane way, dehumanize them, denigrate them, and treat them however I will, because I'm supreme and they're inferior. But when we talk about overt white supremacy in this country, we look at the socially unacceptable issues, the lynchings, the hate crimes, the swastikas, the N-word, racial slurs, jokes, neo-Nazis burning crosses, but we never look below the surface, to that which is considered socially acceptable, although there people are talking about it a bit more. But when you look at some of the latest data and statistics, we've got a long way to go before, we look at the bottom of this pyramid and understand, that whatever seems to be socially acceptable must also be considered unacceptable. I'll let you glance at that for just a moment. You'll see all the different microaggressions and macroaggressions that exist there, and how those chronic stresses build up and lead to the development of chronic diseases also too. So let me move forward with a little bit more. One of the unfortunate things that we teach in schools is still about the lifeboat scenario. And so there are trade-offs between collective goodwill and individual rights. So right now, this is just a thinking point as we talk about exploring your metacognition, which is what I always tell the students: thinking about thinking to improve your thinking. Again, metacognition for this talk is defined as thinking about thinking while thinking to improve your thinking. And so, what is the ethical problem? What information is needed? Who are the stakeholders? What values are relevant to the problem? What options are available? What type of values are served in light of financial, political, and organizational constraints? And what is the process, or what process is best for decision making? Who makes it, and who ought to be involved? And as you can see, we can't fit everybody into lifeboats. We need to be more proactive than reactive in many ways and have some really interesting dialogues and not debates. And I say dialogues because having worked in peace studies and developing strategic peace building education, I've come to really understand that, dialogues are more important, because when we talk about debates is a winner take all, and we never get to the problem because each side is equally proven who's right and who's wrong. But we never talk about the issues in any concrete way that brings about social cohesion. Not to mention that when you have debates, there are winners and losers become frustrated, and that breeds more conflict, and that leads to other types of, crazy issues. So when we look at African Americans, for example, and I'm bringing this in from the issues from African American studies, you'll see that, when you look at this Venn diagram, you'll see that there's this Euro-American attitude or perspective that says that people of African descent are weak, they need to be dominated, and therefore they're inferior. So they have these conclusions. So it's a very reactionary lens and a very narrow concept of Black behavior, thoughts, and lifestyles. And that viewpoint sometimes is a bit of myopia, and it really looks at people who are considered ghetto-centric. But in moving through this timeline of this historical dealing with the Ma'afa, the great African Holocaust of slavery and the trauma from that, you see with some people who have gone from being African to being Negro, from being colored to Black, and how during the 60s, they're inside of the interstices of fish's bladder with the intersections. Some people see themselves as African American, and then some have grown and say, I see myself as African, and develop Afrocentric behaviors, which emerges from that frame of reference, which doesn't need to validate itself to white paradigms in that sense. It's a much more proactive stance. And with that notion, it does lead to menticide and other issues in terms of people being dislocated from their culture and their history. So let's look at this notion of public health systems and syndemics. And syndemics basically is a term that's used in medical anthropology that really sort of talks about comorbidities. And this is something we've seen also too with the arisal of SARS 2.0, which I like to call it, because this is biologically virology. It is SARS, this organism. And when we look at the pre and post issues of this, we'll see how much we have learned that people who've been the most vulnerable in societies, who have pre-existing conditions, which in some cases, because of racism, being Black or being a person of color is a pre-existing condition. But as we look at this notion of multiple chronic diseases piling up, that just adds to the disorder, to the dysfunction. So if you look to the left here, you see we have two trees, and we see that our environments cultivates our communities, and our communities nurture our health. One tree is obviously thriving, and the other is not. And the tree that is not thriving, is a situation where inequities are high and community assets are low, and health outcomes are their worst. So if you look at the roots of that tree, which is feeding on adverse living conditions and segregation and poverty and poor quality schools and occupational hazards, institutionalized racism, discrimination, unemployment, environmental toxins, marketing of tobacco and alcohol, sugar and salt, you can see also too. It feeds into this notion where the tree trunk of that community has, exists within a notion of fragmented systems, restrictions on power, a disinvestment in those communities, disconnection of members, and the chronicity of dealing with those stressors leads to the biological development of, distress, obesity, heart disease, depression, malnutrition, infant mortality, violent smoking, etc. Now, one of the things that we have to do to undo this notion, or this viewpoint, is move away from the notion of biological determinism, which is an old racist concept. But if we move to the tree that's thriving, obviously inequities are low, community assets are high, and health outcomes are their best. So the tree that's thriving, you see the roots have quality schools, access to healthy foods, access to healthcare, transportation resources, living wages, quality housing, clean environments, health insurance, adequate income, as I said before, good jobs, access to recreational facilities. And the communities have improved organizational networks, political influence, leadership, participatory leadership, social support, societal networks, or social networks, a sense of community. And those disease conditions, those chronic diseases are less, and they're less severe in many ways. But I say this because, I like this notion of talking about structural violence. And when we talk about structural violence, we're talking about disparities, disabilities, and deaths that result when systems, institutions, policies, or cultural beliefs meet some people's human needs and human rights at the expense of others. So structural violence creates relationships that cause secondary violence to occur. For the most part in this country, we're always talking about secondary violence. We're talking about self-destruction, alcohol abuse, drug abuse, suicide, depression, internalized oppression, or community destruction. crime, interpersonal violence, domestic violence, rape, or issues at the national, international levels, rebel movements, terrorism, suicide, civil wars, revolutions, schools, war. So I think that, from my perspective, while it's necessary to talk about secondary violence, I think in doing this root cause analysis, we have to look at the root cause of this. What's causing the structural violence to begin with? What's transforming those systems into such a heinous perspective? So our reactions and responses to structural violence are secondary violence, and we need to step up a little bit with that. So structural violence, human suffering, from my work and my studies, I clearly think that these are human rights violations. And when we talk about social structures, we're talking about economic, political, legal, religious, and cultural issues that stop individuals and groups and societies from reaching their full potential. This creates more stigmas. This creates more, racism on certain levels. It creates more, there's a loss of dignity there. And the thing about it is that, this structural violence is embedded in the political, economic organization of our social world. And why is it violent? Because it causes physical and psychological harm to the individuals and communities that result from exploitation and unjust social, political, and economic systems. So when we talk about poorly designed policies that yield inadequate food, housing, health, just working conditions, people live in a life of oppression, exclusion, exploitation, marginalization, and collective humiliation. And it's no fault of their own, really. The one thing I want to say about oppression here is, as we talk about racism and genderism and things, I really think that we need to talk more about oppression in that sense, rather than looking at the lowest common denominator or seeing a small slice of the pie, where sometimes people say, the only one to talk about racism or genderism or ageism, sexism, or disability issues, it's all oppression, and so we've been divided up into fighting against ourselves in terms of oppression Olympics, and so again, who are most vulnerable? Women, children, and elders, and those from different ethnic, racial, cultural, religious groups, and sexual orientation. What are the alert signs to this? Disease outbreaks, poverty line indicators, basic needs index, unemployment, youth without jobs, food shortages, famines, violence, oppression, political instability, corruption, disintegration of government institutions, and migration. People move, they take flight, because they find that the humanity is in question and they need freedom. So as we think about early childhood brain development and adverse child experiences, we have to think about the life course trajectory, the cradle to the grave issues. And so if we're going to improve the intellectual currency of effective public health services and research in academia, there are 4 things we have to look at: the organizational structure of those services, the financing of those structures, the technological data and methods, and the workforce issues, and the training that takes place with this. And this gets us to this notion of really sort of dissecting or deconstructing institutionalized racism. It's interesting to note that PPACA, the Patient Protection and Affordable Care Act, people always in this country, since this act was introduced, most of the people have only been talking about the insurance components of this, which fits into the medical model. But that act, and people haven't paid attention to this, there were several provisions that really focus on public health and population health and prevention. There's monies and funding to increase public health workforce and strengthen quality management, loan repayment programs, workforce grants for state and local programs, public health fellowships, preventive medicine training grants, and reauthorization of public health workforce programs. And those are good starting points, to really sort of get into this notion to say, yes, cure is important, but prevention is better than cure. So, just to remind you about this issue of trauma and social location and adverse child events, as we talk about from conception to death, we'll see the ACEs, we'll see the social, emotional, cognitive impairment, the adoption of health risk behaviors, the disease, the disability, social problems, and early death. The other side of this is the microaggressions, the implicit bias, and epigenetics, with generational embodiment of historical trauma. Trauma is that gift that keeps on giving. It's cross-generation, it's multi-generational, it's intergenerational. And so when you live in socially toxic environments, those social conditions, we have to deal with the local context. We have to talk about complex trauma and ACE. We have to talk about allostatic load and disruptive neurological development and coping, and the burden of diseases from the distress to criminalization, stigmatization, and early death. By and large, as we look at these external stressors, we have to be aware of this concept and ask the critical question, not what's wrong with you, but what has happened to you, which guides us to better, opportunities to get people's narratives about their embodiment. So again, rather than what's wrong with you, what has happened to you. And one of the things I'm always telling the medical students that we can't treat people with pills and medicines and put them back into socially toxic environments. It just doesn't work. It just doesn't work. So we have to talk about trauma and social location and what that means, again, in terms of cradle to the grave services. The chronic stresses and life events, just, to give you another viewpoint of this initial notion of allostatic load. People have stressors, And with those stresses, there's uncertainty, there's fear, there's anxiety. And people usually make an appraisal about that exposure, and take a survey of their personal factors. And if they've got the resources and things that are necessary, it usually winds up being eustress, good stress. And be mindful, those of you who remember the film Unnatural Causes, the only person that doesn't have stress is a person that's dead, But if you've got the resources and personal factors, which education is the most robust predictor of health and well-being. But in this country, we tend to think of education as the most robust predictor of wealth attainment. But those who don't have those resources, they have more distress, and then the stress response takes place. And then there's usually coping and intrusive thoughts. And with that, there's opportunities for increased smoking, alcohol, use and abuse, inadequate diet, substance abuse, physical inactivity, issues in terms of adherence and compliance, a loss of adherence and compliance with treatment regimens, or health promotion, disease prevention regimens, the physiological effects in terms of what happens in terms of a person going through immunocompetence, suppression, or deficiency. And then at the far end of that scale, suicide, homicide, and genocide. So at the individual level, we can see that, you look at this pyramid and you see the dark, the solid black line in the middle, at the top of the pyramid, you see the cell response and the host response. But let's go below that solid dark line for a moment and just look at what's happening below visual change on the left side. You have exposure without cell entry, you have incomplete viral maturation, and then you have, cellular transformational dysfunction, and then the death of the cell on a cellular level. To the right of this, at the below the solid dark line to the bottom right, you have subclinical disease, you have exposure without infection, infection without clinical illness, and then it moves into clinical disease, moderate severity to mild illness, or clinical and severe disease to fatality, host response. And quite frankly, when we look at an institution like NIH, all of NIH's work really is basically dealing with cellular response issues. We know more about the pathology of illness rather than we do about the health promotion aspects of many of this. So more to be said about this. So as we think about this notion of minority health and health disparities, which again, I prefer not to use the term disparities because we've been looking at disparities for 400 years. We know the differentials exist. We need to talk about inequities because when we talk about inequities, we're implying that there has to be a sense of justice that's applied to this. But as we look at, syndemics and people having multiple organic issues or organ issues, it does become complicated. And it can't be solved alone by just looking at the biological or the behavioral, the physical or built environment alone, or the social cultural environment of the healthcare system in terms of those domains of influence. So at some point, as we look at the levels of influence, we have to start thinking about, the societal issues, in terms of population health and community health, and as well as issues in terms of family and organizational health. This does not mean that I'm against individual health, but if you look at our healthcare budget within hospital systems and realize that our healthcare budget out of HSS is close to $3 trillion, a year, and 95% of that is spent on treatment at the individual level, and very little is spent on, health promotion, disease prevention, or community health, or population health, where we look at, the spaces in which zip code matters more than genetic code. This is just a model for systemic approaches to health and disease. And again, there's A, B, and C. How do biological processes and pathophysiology of co-occurring conditions interact? And again, we have to look at the structural and social inequalities that shape the risk of exposure to environmental and social stresses that contribute to inflammatory responses, antiviral activity, and other disease processes. Or B, how are the conditions experienced by patients and their social networks? Again, culture shapes the meaning associated with the suffering and social responses to suffering, illness, and disability, and structural and social factors impede adherence to clinical recommendations. And C, how do medical institutions address co-occurring, conditions? Again, culture influences categorization of medical specialties, the training models for health workers, the financing of health systems, the stigma among health workers, the structural and social inequalities that impede access to care, and social policies promote and impede good health. So we need to critically rethink, all these approaches, particularly in a post-COVID era, as we await the next great pandemic. But racism is a public health issue. And I borrowed this term, equity flattens the curve, from my work with the American Psychological Association in health, and as it relates to health equity. Equity flattens the curve. Everybody was talking about all these other issues, but the norms that are important for understanding how to dismantle that are not being addressed. So as we look at, the response over time and see the acute stress levels, the increase of hormonal levels, in terms of brain function, enhancement of innate function, the transition with metabolic changes, the alteration of the immune system, and osmoregulatory disturbances, the secondary response, and then in time, that chronic stress, the changes in the whole creature, the suppressed immune response, increased disease susceptibility, and behavioral alterations. At some point, we have to really think about the social, political, and cultural environment in which we find ourselves. So that means let's do a power analysis and look at the pathologies of power. And if you haven't been familiar already, read the pathologies of power. Gosh, his name escapes me right now. Come back to me in a second. But let's look at pathologies of power and analysis of power and leadership. You know, we have to think about the types and sources of power, power over, you know, getting someone to do something against their will, which is positional, obstructive, institutional, cultural, or structural, power with others, influencing an action based on unity. It's referential, it's co-powering, it's collaborative, it's transcendent, it's institutional, cultural, and power from within, influencing an action based on intention. And the key word there is intentionality and mindfulness, and clarity of vision or charisma, and expert ideological, personal, cultural, transcendent issues. You know, Voltaire once said that, those who have the power to make you believe absurdities also have the power to make you commit atrocities. You know, let me repeat that. Those who have the power to make you believe atrocities have the power to make you commit atrocities. So we have to think about power in terms of the agenda setting, in terms of the context, the process, the content, who are the actors, who are the individuals, the groups, the organizations, and how we stream this for change, you know, and how do we develop better advocacy coalitions such as what you folks are doing, you know, and working with street level bureaucrats. And again, if we understand power and powerlessness, we have to understand subordination. You know, an active process by which an individual group is placed or treated as lower rank in relation to another person, that it exercises great authority, power, and influence. The ingrained racial attitudes which are endemic in the social systems, education and housing and financial resources, employment, promotion opportunities, judicial and police systems, economic systems, technology, manufacturing. One thing that COVID has also, you know, shown us now too is about the digital divide also too. And again, think about issues or systems of social mobility. So it comes to this question: how do people manage to maintain an integrated sense of self and positive self-esteem? And I should say self-worth there, but this is a quote from someone. And I say that because this is more than just the negative issues in terms of emotional issues, but it's also about self-worth in terms of self-confidence and motivation for change. So when forced to confront routine acts and images directed at denigration of self and your birth group. So let's move back to African descent people again, you know, because we seem to be the canary in the coal mine with so much of this in people of color. And we're subjected to excessive Eurocentrism and structural racism. And to the right of this side, to the left of this side, you see that I've listed something that I call the American Nightmare, 500 years of whiteness. And again, not skin color pigmentation, but an ideology of property, possessive investment, privilege, performance, terror, privileged supremacy, and racialized social systems. You know, so when we look at the context, the dominant consensus on race, and my work with the Institute for the Study of Race and Social Justice on main campus here at UNM, you know, when we talk about race, we put it in quotation marks to let people know that it is not a biological concept, that it is a political, social, economic construct. But when we look at the context, you know, we see white privilege, as part of the national values, the contemporary culture. The manifestations of that, you know, are processes that maintain those racialized hierarchies and racialized public place, institutional practice and outcomes, inequalities and current levels of well-being, and a diminished capacity for individual and community health improvement is undermined. And so there are ongoing racial inequalities with this. Other studies on whiteness have shown also too that it has three characteristics. Whiteness is an ideology. First, people who adhere to it are irrational. Secondly, intellectual growth is stunted, you know, underdeveloped. And last but not least, democracy is negated. So public health is a social institution, it's a discipline, and it's a practice. And we have to start thinking about workforce development that talks more than just about the technical aspects of maintaining that power and privilege as an institutional entity. And how we look at the change within changes of technology and social values. But we have to reduce the 6 Ds of clinical outcomes: disease, death, disability, dissatisfaction, dollars, and discomfort. So I put this in here for those who've had some public health practice experience, you know, in schools. And you probably know that as we talk about, you know, there are 3 revolutions in public health in terms of the practice and epidemiology. The first revolution was infectious diseases, which we should never forget because of changes in the environment and climate things and everything else, and zoonosis in particular. emerging infectious disease is always ready to come back at us. But the second revolution was chronic diseases. Okay, the third revolution is social issues and social determinants of health. Now, many of us have, you know, at least back in the early 80s when I received my master's in public health, we talked about the 3 core functions of public health: assessment, policy development, and assurance. And inside of that circle, inside of those 3 core functions, we talked about the 10 essential services: monitoring health, diagnosis and investigation, informing education, empowering, mobilizing community partnerships, developing policies, enforcing laws, linking to provide care, and ensuring competent workforce, and evaluation and research. This is also about, you know, this issue of understanding surveillance in terms of collection, data analysis, interpretation, dissemination of data, and how that turns into public health action for priority settings and planning and evaluating disease through investigation, control, and prevention. And the thing that's bothered me the most in this COVID thing is that we're hearing a lot about medical surveillance, but not enough about public health surveillance. And you can see this in the people they choose to be the spokesperson for this also too, and how those hierarchies exist. Again, health promotion, protection, disease prevention and control, issues related to primary prevention, you know, those who are susceptible and effective to reduce the disease incidence. The secondary prevention, looking at asymptomatic folks to reduce the prevalence and consequence. And then tertiary prevention, those who are symptomatic, reducing complications and disability. And again, more emphasis in our society is placed on tertiary prevention, you know, rather than dealing with secondary prevention or primary prevention. This is just a brief diagrams to show you the importance of health education, health promotion, you know, and the interlinkages that exist there. This is a new model, and I'm still processing this new model now that's coming out of public health management. And they're talking about getting rid of the 10 essential services and 3 core functions, and talking about the 3 buckets of prevention. Traditional clinical prevention, which is increase the use of evidence-based services, which we still haven't done enough meta-analysis to really understand, you know, promising practices. You know, we should talk about promising practice because there's no best practices as of yet, really. Innovation, clinical prevention, provides services outside the clinical setting, which is important. And implementing interventions that reach the whole populations. And I think that's a good bucket there in terms of looking at the total population of community-wide prevention. As I said, I'm still working with this, but I can see that as we talk about the 3 buckets, we are moving in a really interesting way. So last but not least is this culture of health equity, meeting progressive obligations for dignity and human rights. You know, it's important that we think about this through the eco-social model and social epidemiology. Back in 1980, Donna Beatty came up with a structured process outcome model that says how we look at health systems and services and patient outcomes. And so we think about the structure, the process, and the outcomes. The structure refers to the physical and organizational properties of a setting in which care is provided. The process is the treatment or service being provided to a patient or community, and the outcomes are the results of that treatment or service. So again, as you look at these circles, these semicircles, we'll see that, you know, this is less about individual knowledge, attitudes, and beliefs in some ways, as it is about the interpersonal, the organizational issues, community issues. But I'm going way upstream on this and say we have to look at policy issues. And again, this gets back to the work we've done in New Mexico with unnatural causes, working upstream, and how we look at local, state, national legislatures, federal government agencies, and national advocacy and nonprofit organizations to change the policies that have the most impact on the structure, process, and outcomes of living. So how does this relate to, you know, this work? We have to talk about the types of racism and related stressors, life events, which can be time limited. People live through vicarious experiences, observations, and shared reports of others. The daily micro stressors, the chronic contextual issues, institutional, systemic, the collective experiences, perceptions towards one group, the transgenerational or historical effects, and social class. People are dying sicker and younger. So essentially, one of the values for this notion of critical thinking and why it's important to think about those intellectual values is that we have to think about reaching, pursuing, empowering, and making. Reaching, you know, again, reaching out for those left out of using universal policies, mobilizing resources for human development priorities, addressing the life cycle capacities from the cradle to the grave, enhancing opportunities for women and young girls, pursuing inclusive growth, you know, and at some point, you know, rather than saying inclusive, you know, which is the polar opposite of exclusion, you know, we have to think about cohesion also too, as we talk about reducing racism and stigmas and xenophobia. So pursue measures for groups with special needs, the use of affirmative action, promoting human development for marginalized groups. You know, this gets back to improving human dignity, empowering those left out, upholding human rights, ensuring access to justice, promoting inclusion, ensuring accountability, then making, making human development resilient, addressing climate change, maintaining human well-being in post-conflict civilization situations, combating structural violence, and ensuring people's security. I'm doing a lot of work now in terms of health and human security also in that level, addressing epidemics and shocks, and promoting social protection. So, given that notion, we have to start thinking about human rights-based approaches, HRBA, and what is the obligation of the state? Under the state, and when you look at the Constitution and everything else, the state has 3 obligations, and this is seen from a human rights perspective as well: to respect, protect, and fulfill. Not interfere with the enjoyment of the right to health. Protect, prevent third parties from interfering with the right to health. And fulfill, adopting an appropriate legislative, administrative, budgetary, judicial, promotional, and other measures to fully realize the right to health. Unfortunately, in this country, we don't really recognize human rights. We still talk about civil rights, which is basically about property in many ways. But we have to talk about human rights-based approaches. And with that, this is just a sampling of some of the things that have come out of the Universal Declaration of Human Rights in 1948, the Universal Convention on the Elimination of Racial Discrimination, CERD. Do you know that it took 30 years for the United States, to ratify this treaty, the CERD treaty? And we still have not fulfilled our obligations after signing this 30 years later. And what that means, then there's the International Covenant on Economic, Social, and Cultural Rights, the Tbilisi Declaration, the Convention on the Elimination of Discrimination Against Women, the Convention on the Rights of the Child. This is really interesting for me, that when you think about, we have not signed off on many of these things, really. And the fact that Somalia, which has had, civil war for 30 years or so or more, has signed off on the Convention to Protect the Rights of the Children. We haven't done that in this country. And that's a pitiful excuse for a nation that's supposed to care about families and communities and things. And if you don't care about the life and bread of women and children as a society, you're doomed to fail. Then you have the principles of environmental justice, the First National People of Color Environmental Leadership Summit, the Declaration of Indigenous Peoples Earth Charter, the Beijing Declaration Platform for Action for Women, the UN Plan for Action, the Coolangatta Statement on Indigenous Peoples' Rights and Education, the Hague Agenda for Peace and Justice for the 21st Century, the Earth Charter, the Convention of the Rights of People with Disabilities, and the Universal Declaration of Indigenous Rights. And there's so many more of these enormous conventions other countries have signed up on that we haven't even approached in this country as of yet and need to talk about. But that's because we keep electing people to the Senate who push this aside. So one of the primary things that I learned in my work and working overseas with UNICEF and WHO back in the early 80s was I was involved in health leadership development for primary care, and which we now call it primary care renewal. And the components of primary care based upon that Alta Declaration was education concerning prevailing health problems and methods for prevention and control, promotion of food supply and proper nutrition, adequate supply of safe water and basic sanitation, maternal and child care, immunizations against major infectious diseases, especially childhood disease, early childhood diseases, prevention and control of local endemic diseases, appropriate treatment of common diseases and injuries, and provision of essential drugs. This is a little hard to read, but I'll take it. The bottom part about this shows that 30 years since Alma Ata, the shift for integration for global health and primary health care, maternal, newborn, and child health care has gained more attention. And so if you look at the bottom of this, you'll see that we've talked about the Alma Ata in time, in the world, which I got a really great graph about showing how people care about the world and how it's a real outlier. At any rate, we'll see that by 1990, we had this World Summit for Children goal set. The issues for reproductive health issues, women's rights. You have Millennium Development Goals sets in 2000, and now sustainability development goals and things, again, which all are operational vehicles that could help us to move towards greater primary health care for maternal, newborns, and child care. As you see this discussion now, my early work in global health, it's taken 30 years for the United States to even get to this point, even talk about global health. And now many schools around the country are saying they have global health programs. But what is global health as opposed to population health? We look at it in terms of its geographic reach, from a particular community or country with just public health, or with the geographic reach of global health is direct or indirect effect on health and transcends the national boundaries. This pandemic has clearly showed that we know that zoonosis is responsible for about 60% of all infectious diseases. So we need to think about indirect effect on health and global cooperation, as opposed to something that doesn't require global cooperation, but should. Again, the pandemic is reshaping our thinking on that, which it had for some people for a long time, but all of that has been ignored. Again, prevention programs for populations as opposed to prevention in populations as well as clinical care of individuals. And this is what we mean by population health now also too. It's that synergy that exists between prevention and primary care. And then again, health equity among nations and among all nations of all people and the range of disciplines. It's not just multidisciplinary, but it is interdisciplinary. And I should add that my perspective on this is that it's transdisciplinary. You know, again, if it was just based on one single discipline, which public health isn't, you know, the problem with multidisciplinary is that, you know, the two differences that it comes from, there's no integration of thoughts and concepts and ideas. Interdisciplinary, you do have some fusion of that. But if it's transdisciplinary, we're looking beyond, across, and in between those different disciplines for the development of new knowledge. Having said that, I want to kind of go back a minute. I don't remember what. No, oh, okay. As you see this, as we talk about public health training, this is at the master's level. You know, a public health practitioner has to have learned at least 108 different competencies. 10 from biostatistics, 10 from epidemiology, 10 from social behavioral sciences, health policy and management, environmental health services, and the interdisciplinary cross-cutting competencies inside the box there. My argument is that this has to be more than just multidisciplinary, seen here, but transdisciplinary. You know, most people, you know, who do this work wind up just working one area of these circles, and they disregard all the other training that they've learned, and they just see it through that myopic lens on that level. And that probably explains why I need to really give this some more thought in terms of, you know, how this manifests to these 3 buckets of prevention and what it means for bucket number 3. I'm just thinking aloud here, folks, in that regard right now. So anyways, the important part about all this too is this notion of developing cross-sectorial collaborations. You know, let's look at the number and breadth and quality of successful cross-sector partnerships. And this is something that came out of the Alma Alta work also too. The adequacy of investment in partnerships and the adoption of policies needed to support, you know, those collaborations and move forward, you know, with a more comprehensive approach to things. Now, the fundamental of human rights-based approaches of HBR to health, and this is from the Ottawa Charter for Health Promotion and Disease Prevention. And there have been several of these national charters, Jakarta, Ottawa, Indonesia, Bangkok, so forth and so on. But I'm using this particular one from the Ottawa Convention in 1986. And it says that as we look at conditions and resources for human rights-based approaches, if you look at that list, and they listed there, and they talk about peace, shelter, education, food, income, a stable ecosystem, sustainable resources, social justice, and equity. And I've come to understand that, you know, seeing peace is probably the #1 factor. And I say that because peace is hard to define, but we know it's by its absence. And if peace is absent, then that means there's violence all around. That's structural violence. And so we need to work on those issues, those institutional issues that cause structural violence in the first place, that reduces opportunities for shelter and education and food systems and income, and has harm to the stable ecosystems, so forth and so on. And so from the perspective of the Ottawa chapter, it really talks about health promotion improvement and how we become more informed and better advocates, how we enable and how we mediate. And those are some things that really sort of lead into this notion of peace also in terms of conflict transformation skills as opposed to mediation skills or resolution skills. So again, improvement in health requires a secure foundation in these basic prerequisites, you know, and again, you know, health is really what we're trying to help people and citizens do in many ways, is to find the most optimal opportunities for health that they can possibly have under certain circumstances. So there's 7 interrelated strategies for incorporating health in all policies in the United States. And NACHO and ASTO at the county level and territorial level are now preaching this and talking about this, which I'm glad to see. But out of these 7 interrelated strategies, it's about developing, structuring cross-sector relationships, incorporating health into decision-making processes, whether it's transportation, labor, economics, farming, you know, whatever, you know, the health has to be incorporated into those decision-making processes, enhancing workforce capacity, coordinating funding and investments, integrating research, evaluation, and data systems, synchronizing communications and messaging, and implementing accountability structures. So I'm nearly at the end of this spiel, and we'll entertain some questions because I think I have some time still. How do we undo institutionalized racism? You know, which I think in a talk a few years ago for the Health Policy Institute, I called it administrative evil. And it's important to understand that oppression permeates different organizational structures and the characteristics and dimensions. And it's important to think about systems theory as we go through this. Seeing systems and not individuals, and realizing that if you're looking at systems, you need multiple levels of analysis, which means that you need to think about meta-theoretical approaches, all kinds of theories and approaches, because it's just not a one-size-fit-all, okay? So as we look at interacting with the external environment and external forces, you see that when many people are talking about undoing institutionalized racism, most people are still focusing on the individual level, you know, such as implicit bias training, you know, talking about staff members' attitudes, beliefs, and behaviors, but they're not going upstream far enough, in my opinion, on this, in my work. Then there's work at the interorganizational level. That means looking at operations and the internal climate of an organization. What are the policies and procedures that create and maintain those hierarchies and pathologies of power? And this includes staff relationships rooted in hierarchical power relationships. And it's problematic because it decreases the psychological empowerment and promotes powerlessness among staff and clients. And it's highly individualized in some ways and contextual layered and embedded. So it has to be a parallel structure. If you're going to work in implicit bias, that you need to also work on the interorganizational level simultaneously. And then third, the extra-organizational level. As we talk about, you know, institutions being, you know, an instrument of domination, which limits the viability and sustainability of other organizations, communities that they serve. And why? Because, you know, at that level, they control their access to resources, opportunities, and services. And institutions influence communities, public policies, and you know, whether it be regulatory, economic, political, or professional, and how that shapes and how this is shaped by the social, political, and economic context that frame organizational power and, you know, procedures and practices and functioning. So again, we have to think about oppression. And again, as I said before, oppression is racism, genderism, ableism, sexism, you know, disability issues. And oppression is problematic because it leads to 5 types of injustices. It leads to distributive injustice, how resources are allocated. It also leads to procedural injustice. What are the rules that govern and guide that? It leads to retributive justice, punishment, as opposed to restorative justice, you know, and healing. And then it leads to cultural imperialism and moral exclusion. So I think we have to change that dialogue to oppression. And what are the frameworks for equity and justice in this dialogue? I mean, obviously, you can look at the focus of theories and policies and paradigms and see that, you know, the primary dialogue in this country right now is still rooted at the individual level, liberalism, and the person's well-being and individual freedom. And the policy is about a minimalist state and individual rights. And the paradigm is, in terms of distributive justice, what can I justly claim? You hear this now with people talking about masking and social distancing. And that's all from that liberal individual approach. At the institutional approach, you see the theories about deliberative democracy. What is public governance and what is popular sovereignty? And the policy is one about the responsive state and civic participation, civic engagement, participatory democracy. And the issue of the paradigm there, the worldview is there, is about deliberative justice. Who decides and how much? And that's a very philosophical question in terms of epistemology. Who controls knowledge? How is it produced? How is it used? So that means, you know, getting back into our structures for training of public health and population health or other disciplines. You know, who's teaching what, how's it being taught, and what's being taught, and how is it being used? And then the community issues and community theory. You know, what is the public good? What is the common good? What is social solidarity? You know, the policy being a responsive state, public welfare, or social justice. What's good for us as a community, as a group? There's a Latin phrase from Cicero that says "Salus publicus listo suprema lex esto," which means the health of the public is the greatest good. So I'm going to end this right now, and I'm going to ask you folks a couple of questions because I've been yakking for quite a bit here. But I'm going to end with this question from Martin Luther King. What do you want, chaos or community? We have to give that some serious thought. What do we want, chaos or community? And so in the time that I have right now, and you folks are going to go into your breakout session also too, but I'm going to ask you, I'm going to stop the share for just a moment. What did you learn to you that's new? What's new to you that you learned today that you didn't know before? What new piece of knowledge come to you that you didn't know before? Now remember, I'm asking a cognitive question. What did you know now that you didn't know before? You can shout it out or raise your hand, whatever's easier.
I was wondering if did you want people to raise their hand, share in the chat, either
Whatever's
or.
easier for it, whatever's easier. I'm winging it right now. I'm in a jazz mode. I'm riffing. I'm creating something new here. Because I've got 35 minutes before I start teaching my class, so I got some time. So what's new to you that you didn't know before?
Shifting to a transformation skill. I love that. I want more information on that shift.
Okay. Something else that's new to you that you didn't know before.
Someone shared that public health is becoming a more intimate profession.
Okay. So you're moderating, Trish. You're moderating from the chat list, right?
Yes.
Okay, that's cool. That's cool. Okay.
That was me, Dr. Martin.
That was
Oh, I'm
Kenneth.
sorry. This is you, Ken.
Yeah.
Okay.
One that's-
Yeah, because it does. It just sounds like much more acknowledgement of the continuum of individual to system, and you're describing it. It was refreshing to hear public health described that way.
Well, few of us are still describing it that way, quite honestly. You know,
Right on.
something else that's new to you folks that you didn't know before, that you thought about.
There's a comment here from the chat, Dr. Martin, that someone wanted to share about one of their takeaways, but wanted more information about transformation skills. Can you talk a little bit more about transformation skills versus mediation skills?
Okay, briefly, and I would like to save that question for the end because I have two more questions that I want to ask you folks, but I'll give you this, Trish. Transformational skills is about, you know, it's about systems change. If conflict resolution, let's put it this way. Conflict resolution just brings parties together to agree to not to disagree, but it doesn't transform the culture. It doesn't bring about any long-lasting, sustainable thing. Like, say, for example, I've been in a talk that I gave to the legislature a few years ago during African American Day, and the only thing that people remembered that I went off my talk for a moment and I told the legislators to stop all the mental masturbation, because all they were doing was producing a good feeling for a short period of time, and they weren't doing anything that was lasting and concrete or productive. You know, so in that sense, we need transformative stuff because, again, people are suffering. People are suffering day in and day out, and people are not picking up on that, and that bothers me in a sense because, as I said before, the studies in neurological sciences show now that if you do not care about the suffering of others, you are a sociopath, and if you have power, you know, and you're not a fair-minded thinker in that sense, you know, you can do a lot of damage. You can do a lot of damage. So let me ask you a couple of questions right now in terms of cognition. And Trish, you can contact me. We can have some more dialogue about that also too. Okay, we can get a running dialogue about that. I'd like you to process your feelings now, your emotional states, your affective states. When you were hearing all this information, what were your feelings? What type of feelings are going through your mind? Not cognition, not thinking, but feelings.
A total agreement. I mean,
Okay.
I've witnessed it. I've seen it. I've heard it. I've felt it myself. I was into everything you were saying. You were moving so fast though that my brain didn't get to register some of it and say, yeah. So, but I was tracking all the way. I think it was awesome.
Well, to tell you the truth, you know, I don't expect people to retain everything. Just pull out nuggets that's important to you at the time.
Somebody said anger.
And I always ask other questions. Someone said anger.
And everything you're saying is so relevant now with all the chaos. I know that Maria, you had your hand up as well. Did you want to share something?
I see some sadness. Go ahead, Maria. I'm sorry.
Interestingly, mine's a little bit of the opposite, is that it actually feels hopeful. It feels like so many of us are in this same mentality, the same thought. It's like we're preaching to the choir. So how does that then trickle over into that policy making? Because those of us who are impassioned to bring that kind of new paradigm shift into this culture, you know, we're all here. So how does that translate into, you know, beyond those of us who are beginning this awareness or, you know, helping to support one another, but how does that extend beyond ourselves and into really making a effective change? So I feel hopeful, and at the same time, I feel frustrated and a little bit overwhelmed, but hopeful.
Well, I agree with you. Many times I feel frustrated, but when I look at the literature and I look at the things going around me and the conversation we have with people, you know, I do develop that hope again, you know, and I can't lose sight of that hope, that transformative hope, because if I lose that, then all is lost, really. So I live on this notion of having, you know, to be unapologetic for my righteous indignation, you know, to speak for justice and fairness. And if that's all I can do is speak out about it, then that's what I need to do. You know, I have a religious tradition that says that if you see something wrong, you should try to change it by speaking out against it. If you can't change it by speaking out against it, then you try to change it by your hand and grab somebody's hand and say, stop, don't do that. The other issue is you change it in your heart. And I used to think that was the easiest thing to do, but now I'm saying that's the hardest thing to do, to change it in your heart. You know, so it requires this notion of how we become educated and trained. And when you think about it, you know, science and philosophy both search for the truth, and they both look for, they both search for the truth and use similar methodologies. But science only says, how do you explain something? Philosophy says, how do you apply it? And therein lies the rub. How do we apply this information? We're tired of explaining. We're tired of doing X, Y, and Z. How do we apply this knowledge? So that's the paradigm shift that has to take place, you know, which is why I say that I'm tired of talking about disparities. We've been talking about that. We know the differentials exist. We see it every day. Let's talk about inequities and make that stick. Let's talk about the justice and the fairness that needs to take place, and how do we work for that? To be continued. Any other emotional things?
Ms. Hollis, I know you unmuted yourself. I didn't know if you wanted to add something in there.
Talking to me? I'm sorry.
Hi, Chris.
Affirmation.
It's kind of funny. One tiny little nugget that I did hear, and it says to me the importance of words again, and knowing what they mean, is when you were explaining that civil rights is really more about property than human rights. So I have to think about that. The other thing is that I've been spending so much time lately trying to figure out how to bring together, like, the public health system with the healthcare system around, and I'd like to use your word now, thinking myself on this whole aspect of improving the health system, but to think of it more as transformation. And how can you bring the two together? And both professions, if you will, or both parts of this system definitely have inequalities, have long histories of racism and a lot of other things. And how does one kind of bring that together while also, you know, for change, but in the sense of also getting rid of, as what you're talking about, a lot of those negative factors in there, racism and inequalities and everything else. But it's right what somebody said, is you've been speaking so fast with everything that it's going to take a little while.
That's okay. This is meant for people to let it sit and marinate for a while. Throw some zest on it, some bam like this emerald, and let it marinate, you know. And as I said before, this is a challenge to your metacognition, to thinking about thinking while thinking, to improve your thinking. And those who are on that track already, notice that the most powerful tool that you have is your brain. And we rarely use, you know, much of our brain in ways that we should, because we've been trained to not use it. We've been trained to think that we're left brain thinkers or right brain thinkers rather than whole brain thinkers. And so what are those opportunities for getting past that fear and that anxiety that says, I see this as a threat, so I either run away, freeze, or disassociate and do nothing, but getting to the forebrain, where higher executive functions take place in terms of thinking and problem solving, and language takes place, you know. And this is about having the dialogues and the discourse, and not about debates, because language and culture matter, and the language that you use represents the culture that you come from and what that means. And so we live in a colonized space. So how do we decolonize minds and have this dialogue? In some ways, we need to start transforming this culture, you know, to have a culture of health equity starting in preschool, you know, before we move up into you know, well, P20. We need a larger paradigm shift if the human species is going to survive. And one of those issues, like, for example, when we talk about this notion, one of the hardest things I see now doing anti-racism work within this group is getting even people doing, say, they're anti-racist advocates, what have you, is getting to understand they're not multiple races. But you see it still popping up in dialogues. Oh, the multiple races, like, folks, there's only one race, the human race. You know, if you want to get into a metaphysical discussion about, you know, the spiritual realm and think about creatures of another sort, yeah, that's something else. But there's only one race, the human race. We are all cousins. We're all distant relatives. You know, the Human Genome Project has shown that. But people are always saying, oh, there are 8 different races. We're different ancestries and ethnicities, but that's so that we can come together and learn from each other. So we have to change that language also too, you know, and that's another little paradigm shift that I'm working on, so to speak. And I guess so. So yes, sometimes it's frustrating, sometimes it's exasperating, and forgive me for going off like that, but we certainly need more time than what I was been allotted to. But as I said before, I'm welcome to answer email notes and things that are later and have these discussions with you folks as we move forward with this. Someone wanted to see the slide again about caring for the world. So while I'm looking for that slide to bring it up, I wanted to give you some time to think about my third question, because we process our thinking, we process our feelings, our emotions, so to speak. Now that our thinking and our feeling is in alignment, and you folks have already been doing some of this processing, what interpretation are you coming up with? So think about what this all means, and then I'll pull up that slide again. And you can go ahead and answer at any time.
Can you repeat that question, Dr. Martin, please?
Someone asked, oh shoot, I forgot. Oh, the question really was like, I wanted you, now that you got your thinking and your feelings in alignment, what interpretations are you coming up with? What is the meaning of this dialogue that we've had?
One thing, Dr. Martin, that I think of is, I think that you said, or you talked about more than once, which is the importance to move beyond the individual, addressing inequities or injustices just on an individual level, and that we really have to look at it from a higher societal level when we're working toward creating working with our communities to create a world that is equitable and fair.
I like that interpretation, because that's basically what I'm about in that sense. And I think that as we're dealing with the SARS-CoV issue, that this is a great teaching opportunity for us to understand issues about caring for those who are left out, but also too the butterfly effect. What happens here has an effect somewhere else in the world, and how we are one human species. And as we look at the last 500 years under this current Anthropocene, we got all kinds of issues that the disrespect for Mother Earth, the damage that's done, the issues of climate change, sensitivities, human vulnerabilities. There's so much that's here, and we're all in this together. If you notice that on my, can I remove the slide for a moment? Person asked about this.
Oh, of course, yes, absolutely.
If you look at my background, where am I sitting, or where do I think I'm sitting?
Moon?
Space.
In space.
Universe.
I'm not exactly on the moon, because giant steps is what you have to take when walking on the moon, is stinging the police say, but be that as it may, one of the things that we've learned from that realm of science is that when you look back at the Earth and this tiny blue planet, you don't see the physical boundaries and borders and all the other existing conditions that divide us. You see mountain ranges, you see the lakes, you see the rivers, you see the streams, oceans. You recognize, like, this is a very special place, and we have to protect it. And we're all one human family. And W.B. Du Bois in the 1930s did a great speech. And I'm still trying to find the other pieces of the speech, but he talked about the sanctity and the spiritual aspects of diversity, the sacredness of diversity. And I thought, wow, that's a beautiful phrase, the sacredness of diversity, because for me, diversity in some ways has just become this quota system in many ways also too. And in some ways, maybe it has some effectiveness. In some ways, I'm trying to improve social cohesion by including, people who've been excluded. But at some point, we have to include the other issues in terms of dignity and human rights issues, which in this world right now, dignity is not even considered to be a part of human rights, in Western law. It's like, really, human dignity is not a human right? That's scary, So with that type of control and abuse of power, that gives people the leverage to say whatever they want to say, do whatever they want to do to harm people. So the interpretation really is to something that I learned a long time ago, to think globally while acting locally, And when you do that, that's a transformative act in itself also too, when you see those interactions, you know. But unfortunately, we've been trained to kind of see that if the only tool you have is a hammer, then every problem looks like a nail, you know. Or the fact that, you know, if I gave you a microscope, you can only see that which is infinitesimally small. Or if I give you a telescope, you can see things at a greater distance. But if something such as a macroscope existed, you can see the breadth and depth of these issues. You can see the holistic issues and how these interrelations that take place and what that all means. And so that's the next quantum leap. You know, the next leap really, you know, back in Star Trek days, they used to say that space was the final frontier. And I was like, well, yes, no, but maybe the final frontier is what exists between our ears right now, the human brain, you know, and the transformative issues about how we use our brain. It's not nuclear weapons, it's not all this other stuff. It's about how do we use this marvelous organ, you know, in unique ways, and how do we help people from having damaged human organs, you know, through social toxic environments. So yeah, there's a lot to be said. I thank you very much for, you know, inviting me to this dialogue and this conversation. I hope you have some really nice conversations. I wish I could sit in on the next part of this. I got about 10 minutes to get to my next step.
Ife's got a hand up.
About next steps for you, not only as an individual, but as a collective. What are your next steps and what this means? And Ife raised her hand, so she has a question for me, like I'd like to answer.
It's a simple one. How do we contact you?
Oh, that's a real easy one.
Mm-hmm.
My email is Dr. Jamal, all lowercase, drjamal@unm.edu. I'm not gonna use my Salute account because I'm getting too much message. I'm getting too many messages everywhere, but I do answer my emails, okay? And John just put it in perfectly. There it is right there. I do answer my emails.
Okay, thank you.
You're quite welcome. You're quite welcome. So my parting questions for you folks is to really think about what your next steps are as a collective, as a human body that stands for dignity and justice and fairness. What does this mean to you? You know, and how does it impact your work? It's not easy. This is not easy work. I agree with you. It's not easy, you know. So again, I thank you and appreciation for all that you do, because it's thankful, but you didn't get into public health to make money. You know, it's a calling. You know, I don't know what else to say. I throw everything at people but the kitchen sink, hoping that something will stick, because people learn in different ways also too. So
everybody can relate to that statement.
Excuse me?
Most of us here can relate to what we do in that statement, I think, very well.
I think so.
Oh, yeah.
So lean on each other for support and comfort, because as a collective, you know, you folks, you know, while there may be some groupthink at times, but you folks represent a powerful voice, you know, for advocacy and change. And keep growing, keep reading, keep challenging yourself. Don't be afraid to take those risks and step outside of that envelope, because we have been, you know, there's a great book written in 1935 by the father of Black History Month. And he wrote a book in 1935 called The Miseducation of the Negro. And I always say, and everybody else. So we have a system of colonized education that's, you know, and training, you know, to do this. And again, the other facet that I put from Africana Studies with this is that people were not kidnapped and you know, they weren't slaves and kidnapped. They were human beings who were kidnapped and turned into slaves, you know, and they were brought here, you know, to be trained, not to be educated, you know, to maintain that supremacist power. So there's a lot of things that we have to undo, but once we start getting our wheels clicked, and you know, we can do it, and we pass this on to the next generation, because that's our work. You know, as I see myself becoming an elder now, I should say I am an elder. The job is to pay it forward and push it back and get the next generation ready to do this, to bring about those substantive changes, you know, in ways of thinking and doing things. Because again, I always ask, you know, I ask the students, you know, what kind of world do you want your children and grandchildren to grow up in? What do you want? You've seen these problems and these issues. Let's make a difference here and now, you know. And all the theories and models we learn from health behavior theory and education, all these things, integrate them in useful ways. Be transdisciplinary in your thinking. You know, universities don't like it, but I say the heck with it, you know, because most people in universities are trained to think only in one way, in one dimension, you know. And so break that mold. Okay, I just got to note that my class starts in 10 minutes.
Thank you, Dr. Martin. I really appreciate your time.
Oh, you're welcome. Bless you all. Take care and call me anytime, okay?
Thank you.
You know.